Hello and welcome to the webinar today. It's nice to have you with us. It's January. We're at the beginning of a new year, and that's always full of possibilities, isn't it? Whenever we have these markations in the calendar, there are different times to think about different things, and the new year is just full of possibilities. I know a lot of people do resolutions. I don't do resolutions because I never keep them, so I always find that a downer for myself. I'm always disappointed in myself about that. So I like to think about possibilities in the new year and what's going to go on. And this new year should be a pretty exciting one in the world of paralysis. So I'm really kind of looking forward to see what's going to happen this year. First of all, I'd like to take a moment to thank Tim and Beth, who's the information specialist from the Reeve Foundation. Tim is the controller of all of this. They make me look good, so I appreciate that. And thank you also to the captioner who's relating this to people who really need that kind of help and information. And so all the people who are behind the scenes, there's so many people who work on this behind the scenes at the Reeve Foundation. And so what you see is me talking, but it's like the Queen and the royal family. They used to say, oh yeah, we have a production and it looks like the swan swimming on the water, but underneath the water, there's all these people paddling the legs, making this go. And I think, yeah, that's kind of what it's like doing the webinar. I sit and talk, but there are all these people that are doing a tremendous amount of work. So thank you all for that. So what are the possibilities for the upcoming year? And, the topic for today is nerves, but we talk about whatever you want. But I always like to, try to focus on some particular topic. And this month in the blog, I've been writing about nerves because the possibilities for this year include nerve function and all the things that are going on in the research world. Now, we have, over the last year, we've been finding out about a lot of research that's been going on and a lot of things that are progressing rapidly in the world of paralysis research. And so some of those are to come to fruition this year. Now, research is never that simple that we can say on this date, we will have this. There are always things that come up. Many of these projects have been postponed during delays of COVID. So you see, there are all kinds of big things that hamper research. There's all kinds of little things that hamper research and everything else in between. So, but this year we're supposed to have some good findings in the world of electrical stimulation and some products that are coming out on the market. So somebody was asking what's going on in the world of spinal cord research and for all paralysis. A couple of things that should be coming out this year are the new electrical therapies should be on the mass market, which means that anybody will be able to get them anywhere, which is lovely. So there are many companies that work on this. Cleveland Clinic FES Center, which is a great place. I've visited there in the past. I know several of the people who work there. It's really a fabulous place. They have a product on market that's an implant that can help you restore some function, gain some function. And it's kind of modular. So you can implant one thing and then you can add to it as you go along and decide, what you want to do. Onward is a company, you can look that up online. And we talked to them last year and they have a couple of products that should be coming out soon. Now, they're scheduled to come out this year, or at least that's what they were thinking. Now, if they have an exact date yet, I don't yet know of that exact date, but it will be coming out soon. So they have a product which is a spinal stimulator that's implanted, which is some electrodes on the spine. And what's unique about theirs is the electrodes are on a strip. So it's a minimally invasive surgery where they do a little incision over the spine and then they slip this electrode strip down and against the spinal column, and then they control it from outside the body. And so instead of having to open up the whole spinal column and put these electrodes in one by one, they have a strip. So it's much simpler surgery, and that works out very well. And then they also have a program with a skin. So we call that surface electrodes that's taped onto an area over the spine. There's a controller that goes with it, and then you can gain some function by just having this taped onto your spine. You'll see in the chat box, there's a link to the Onward company. There's also a company called SpineX, which I find very interesting. And they have similar kinds of things. They have the implant and they also have an external controller. They're also scheduled to have their external controller come out this month. Both of these companies have similar products. There's differences between them. So you want to look up SpineX and you want to look up Onward. You want to look at the Cleveland Clinic. You can look up electrical stimulation implants and find other companies, because there are other people working on this as well. Or you might find surface electrodes, functional electrical stimulation, because it's electrical stimulation that enhances function. So that's what it's called, FES, functional electrical stimulation. And both Onward and SpineX have great products as well. People that have used them, they've been in clinical trials. I've met people that have used both products and seen what they could do before and what they can do afterwards. Now with electrical stimulation, and this is really cool, I think, is that after you turn the device off, there's a certain hangover time. So you still have the function even with the device off for a certain amount of time after you use the electrical stimulation. So I think that's really neat, because if you have it on for 3 or 4 hours and then for some reason, if you need to turn it off or you need to rest your muscles and your nerves or whatever, for whatever reason, you'll still have a little bit of time, not the first day, but you'll still have a little bit of time over time that you can still do things. Now, is it like you were before your injury or before your disease affected your nerves? No, it's not the same, but it's more function than you have than without it. So if you're interested in that kind of thing, now not everybody is. I'm not saying, oh, you must run out and get one of these. These are decisions that you have to make for your own self and what you are. There are plenty of people out there that are flourishing in life without even thinking about these things. So, it's up to you if you want to do some of these, try some of these products, or if you're interested, but get all the information first so you can see if you think this is something you might be interested in. Even if you're not interested in it, it's kind of interesting to hear about it, because there might come a time in your life where you might think you can change your mind. And so if you do become interested in it later, it's good to kind of have all this information so that you know what's going on with that. So those are some of the things that are going on. Now, there's always questions about stem cell therapy, and there's been progress made in that they can get the stems, they know how to make the stem cells that will turn into nervous tissue. So you don't want, say, cardiovascular stem cells in your nervous system, because you don't want, they function differently. They won't work in your nervous system. So you don't want that, but they know how to make stem cells become nervous tissue every single time. So they have that down. They know how to get it into the spine. They know how to, once it's in the spine, when you have a spinal cord injury or an issue in your spinal cord, the cord creates a cavity in the center. Even if you are pressed, your nerve is pressed like from the bone on the outside of the spinal cord itself. If one of your spinal board vertebrae presses in on that spinal cord, the damage forms in the center. So there's like a little hole. So if you were to cut your spinal cord this way, you wouldn't want to do that. But if you were to look at that and you would look straight down into it, it would look kind of like a little donut with a hole in the center. And that's what happens in the spinal cord. So they know how to get that in there. And then they've established scaffolding. So if you think like the outside of a building, if somebody's going to paint it, they might put scaffolding on the outside of the building to be able to reach all the points. They can build little microscopic scaffolds out of tissue inside that spinal cord so that the stem cells have directional ways of going. So there's a lot going on there. There's still a long way to go. That's a much more complicated process in creating stem cells. So that's taking a bit longer than we thought. 20 years ago, stem cells were all the rage. It's coming any second. And indeed, there were a lot of laboratory experiments that did work out in that regard, but it's taking a little bit longer than we thought it would, but work continues there. And there's still all the other therapies that are going on. So there's the electrical stimulation that's being used in therapy, the FES spikes, all this activity helps stimulate the nervous system. The nervous system wants to rebuild itself. It's anxious to do that. You know, a lot of people think, oh, if you damage the nervous system, it can never be fixed. Oh, yes, it can. And science has proven that the nervous system wants to do it. So nerves are trying to send and receive messages to and from the brain, through the spinal cord, from the body. It's trying to do this. And the nervous system will try to make workarounds so that they can get past the area where the message is not getting through. It does it in the brain, it does it in the spinal cord, it does it in your body. So all these things continue. It just happens to be that right now we're kind of in this boom of getting a lot of new things going. So that's very exciting. So today we're talking about nerves and how nerves work. And people have gone through the body and they know a lot about nerves, the anatomical setup of nerves. Nerves, a single nerve consists of many bundles of nerve fibers. And they have mapped the way all these individual nerve fibers work and how messages cross from one nerve to another. And so this is, you know, they've made a lot of forward movement in there. So there's a question that just came in. Does this neurological procedure work just for the incompletes or from the completes as well? Actually, the FES works better in incompletes because of the amount of stimulation that it takes to do some of these functional tasks. Creates sensation. So it works better. Well, I shouldn't even say that. It works differently if you have sensation versus if you don't have sensation. The internal you can do with either, and the external you can do with either as well, with incompletes or completes, but the amount of amplitude of the electrical current is a bit different. So yes, incompletes are working this as well. So there's opportunity for everyone. You know, it's just a matter of fine tuning it for different individuals. So talking about the nerves, I also wanted to talk about this month. You know, we know about the nerves in the brain. We know about the nerves in the spinal cord. That's the central nervous system. And then there's the peripheral nervous system, which are all the other nerves in your body. So the nerves in your arms and your legs, and they're all connected through the spinal cord to the brain, except for the cranial nerves. And the cranial nerves basically service your face and your head. And then there's a couple that go down into the trunk of your body, like the vagus nerve that helps with heart and digestion and all that kind of stuff. But those work a little bit differently. And the reason why I wanted to bring them up is because sometimes people get a facial paralysis, and that's through the facial nerve. That's a cranial nerve. So it's a bit different because it doesn't travel through the spinal cord. It comes out at the base of the brain and it travels around. So they're different facial nerves. They're different nerves for the face to make your eyes blink, to make your eyes move back and forth in a coordinated manner, smell, chewing, all these things that make your face work. And so it's important to know because sometimes people get a facial paralysis. And so it's a little bit different than, you know, if you have a spinal cord injury or if you have an injury in your brain when you have a cranial nerve paralysis. So you might have a facial droop. But if you have an injury or if you have a disease progression, people might not notice that right away. So it's a good thing just to be aware of that kind of thing, in that because mostly families will notice. So sometimes, especially if you've been through some sort of trauma, you know, you might have some swelling on your face, or you might have had a surgery that made some facial swelling, because when the body's injured, that's the way it wants to protect itself, by supplying fluid to the injured area so things swell. And that's a normal thing. So Sometimes the healthcare people might not notice that you might have a facial paralysis because of the swelling. So family members will notice first. They'll say something doesn't look right, more than just the swelling. Now, in particular with head injury and spinal cord injury, sometimes people can get damage to the facial nerve, which will cause something called Horner syndrome, where one eye it's a problem that the eye is droopy. The lower lid doesn't droop, but it doesn't hang down as far. You have trouble closing your eye. You might have some trouble moving your eye. And so that's something to be aware of. There are other issues that can happen to facial nerves, like you can get a facial droop. Sometimes these facial nerves will tell you that something's about to happen. Like when you get a droop on one side of your face, your eye is droopy, maybe you have a little bit of saliva coming out of one side of your mouth. Those are all symptoms of a stroke or a TIA, an oncoming, you're either having a stroke or a TIA. And so that can be a warning that something's wrong. So facial nerves can tell you something's wrong, or it can be that facial nerves affected after a stroke. Or Bell's palsy, which is nobody really knows what causes Bell's palsy, but people think it's virus. Scientists think it's virus. So sometimes you'll get a facial droop that has nothing to do with the stroke, but it's Bell's palsy. You suddenly get a facial droop and you're just living your life. You suddenly have a facial droop, straight to the hospital because you could be having a stroke. It could be Bell's palsy, which usually resolves on its own in 6 months. If it doesn't, what they'll do to treat that, if it remains longer and you have a facial droop on this side, they can't really reanimate the face to pull that up. So you might get Botox on this side just to even it out, so you don't have this differently shaped face on either side of your body. But eventually, the Botox will wear off, and eventually Bell's palsies most often correct themselves over time. Sometimes people get what trigeminal neuralgia, that's the trigeminal nerve, it's a cranial nerve. And it looks like a W sideways on your face, kind of like this. So if you think the branches of this trigeminal nerve comes out, and that's the way that fits both sides of the face. And that can be very, very painful. It gives you nerve pain. So that's important, to know about those kind of things. Just because it's a little bit different and people often don't think about that. Sometimes with disease, you might have some facial issues. Sometimes with spinal cord injury, you can get something like the Horner syndrome. And so all those are just important sidelines to note. So I just wanted to bring those up. Now, nerves can get damaged, as we all know. That's why we're here. And usually what happens is they get overstretched. So if you flex your neck too far this way, or you flex your neck too far back that way in a trauma, then the nerve gets overstretched, and like a rubber band, if you pull it too far, it doesn't snap back the way it should. So that can cause trouble with paralysis. Sometimes there's that impingement where a piece of bone or a tumor or a blood vessel presses on the spinal cord or in the brain, which is pressing against those nerves. And so sometimes there's a function that happens there. I also wanted to mention that sometimes people hear the word complete injury. This can be people in the community. This can be healthcare people too. I've heard them say this too. They say, oh, you've had a complete injury. That means your spinal cord is completely severed. That so very rarely happens. Even if you have a knife injury or a gunshot injury, it's really hard to sever the whole entirety of the spinal cord. It's possible, but it next to never happens. So there's always threads of the spinal cord that are still connected, even if the messages aren't getting all the way through all the nerves because of the overstretching or the impingement or the other ways that you can hurt your spinal cord. But there's always ways for messages to get through. So there's always hope. Now, the reason why people get confused about the complete injury thing is because when they do the testing, the ASIA test, I'm sure you've all had that. It's where they test all your muscles and all your nerves throughout your whole body. So when you have an ASIA, that means at this particular level of the spinal cord, no message is completely getting through. Okay, that's where the word complete gets confused, because people read that word complete Now, most healthcare professionals know, but they'll say, oh, they might tell you, oh, you have a complete injury, and people think, oh, my spinal cord is completely severed. So next to never does that ever happen. So I just want you to know that there is hope in that regard. So with that, there's some questions. And this first one is there any non-drug treatment that helps with leg spasms? And yes, there's stretching exercises that can help with leg spasms. That's kind of like your first line of defense with leg spasms. So if you think about, you get a cramp in your leg and you don't have paralysis, what's the first thing you do? You stand on it and stretch those muscles the opposite way, because the muscles are in groups throughout your body. There are muscles that pull and there are muscles that push. So when you get a spasm in your leg, one set of the muscle is stronger, reacting stronger than the other set, because the pulling, pushing, they keep in balance. And so one set is acting stronger than the other one. It's a miscommunication. And that muscle, it could be a metabolic problem, but usually in brain injury or spinal cord injury, it's a miscommunication, and those one set of muscles is tightening and the other isn't able to counterbalance it out. So that can cause a lot of pain. So one of the first things to do is to stretch that muscle so that you can relax it and work on that either through muscle massage or work on stretching that muscle, help relax it. So that's kind of the first line of defense. Even if you're taking medication, sometimes if you're having muscle cramps or leg spasms, you can still do that stretching, and that will help relieve that particular episode at that moment. And so that is really a non-drug thing that you can do. That's really very helpful. And people often overlook that, probably because it's such a simple thing. And spasms are such a complicated issue that people, always think, well, boy, this is really painful, significantly painful if you have sensation. If you don't have sensation, it can set off episodes of autonomic dysreflexia, or it can just, you can just feel generally miserable. Sometimes people are just self-conscious about it, because sometimes those spasms get chronic where they have a rhythm to them and their legs bouncing, and they feel a little self-conscious about that. So if you do stretching on that leg, it will stop that clonus. It will stop that bouncing, that repetitive bouncing. So you can kind of break that as it goes. Oh, so our next question is, we explain nerve regeneration and what it may feel like. Well, actually, nerve regeneration, you probably won't feel it, which is kind of a nice thing. But the nerves are regenerating all the time. If you have paralysis, if you don't have paralysis, there are nerves that are regenerating all the time. Now, you probably learned in school that once you have your nerves, and that's all you'll have for the rest of your life. But that's not true. Nerves turn over like skin cells, like every other part of your body. They get old and new ones come and take their place. But in the nerves, it happens very, 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 very slowly. And so, skin cells turn over really quickly. Nerve cells are one of the slowest to turn over, but they're always looking for a receiver. So a nerve, if it gets separated from the next nerve that it's sending messages to, it will be looking for a receiver. So sometimes that nerve will connect to another nerve, and that can cause neuropathic pain because the message is not getting through correctly because it's attached itself to a different set of nerves. Or sometimes neuropathic pain can come from other issues as well. But that usually you don't feel nerves regenerating. They're regenerating in your body right now, and you don't feel that happening. It just happens. So that's kind of a cool kind of thing. Now, if you have that miscommunication, sometimes you might feel neuropathic pain. That's just a mistaken message. Sometimes if a nerve can't get the message to where it's going, it releases its chemical energy, because those messages are chemical exchanges in the body. And so sometimes it's releasing that chemical energy. And so you might feel pain from something like that. But in general, nerve regeneration isn't bothersome at all. So, and that's in the central nervous system, and that's in the peripheral nervous system. The peripheral nerves do regenerate at a much faster pace. Those are the ones that are the nerves outside of the brain and spinal cord. So if you have a nerve injury in your arm, the nerves will regenerate. They usually regenerate at a rate of 1 inch per month. So if you think about, you have a nerve injury up here in the brachial plexus. If you measure from the brachial plexus all the way out to your fingertips, and on me, that's going to be over 36 inches. So that's going to be 36 months till that nerve regenerates, function all the way down to the tip of the finger. In the central nervous system, it doesn't work that way. They don't regenerate that fast. So, but in the peripheral nervous system, they regenerate really quickly. Sometimes we can help that along with different nerve grafting or nerve transfer procedures to help increase the function. Therapies can be used to do that. So there's a lot of things, you know, you want to get to the source of what the problem is, where the peripheral nerve is not regenerating. If there's pressure on it, you can release that, or you can do some of these transfers and stuff, so that can help boost that along. This next question is in here, off topic, but that's okay because we talk about all topics. And it's also a question that somebody wrote in about, can a person with spinal cord injury treat malfunctioning of bowel and bladder? And here's a question about bowel care and hemorrhoids, prolapse bleeding, best treatments. The GI team, I think maybe you wrote this question in. I think I read this early too, but maybe it's just two people with similar question. So they want to do surgery. So, okay, so let's just talk about bowel and bladder are treated with bowel and bladder programs. And we'll put up some links to how to do those. So that is the treatment for spinal cord injury, is you have to do a bowel and bladder program to manage that. The urine will collect in the bladder, the stool will collect in the bowel, but it has to be extracted from the body. In the bladder, it's most preferred is intermittent catheterization, but there are other caveats to that. Some people can't do intermittent catheterization because of hand function. For women, positioning can be a challenge if, you know, like if they're going to work and they can't, you know, separate their legs enough to do a catheterization, or they don't have the balance. There's men with retracted penises. Sometimes they'll use a Foley catheter. Sometimes they'll put in a suprapubic catheter, which is a catheter that's surgically placed through the skin of the abdomen right over the bladder, so that urine can constantly be removed from the body. So that's the way you have to, you know, it's like urine will collect in your bladder, but you have to go in and fetch it to get it out. So that's just something that has to be done. Now in the bowel, it's the same kind of thing. And usually what happens is in people who have a lot of tone in their body, those are people who have cervical or thoracic injuries. So they will do a bowel program where they'll do digital stimulation. They'll use some kind of stimulant, either a suppository or a mini enema, and that will help bring the stool into the lower rectum, and then use digital stimulation to relax the inner sphincter of the bowel to let the stool come out. Now, a lot of people think they've got to relax the sphincter, and you can see the external sphincter. That's the opening to your rectum. You can see that on your body. But that's not the sphincter that we're interested in. We're interested in the inner sphincter, which is about 3 inches up inside the rectum. And if you have tone because you have a cervical or thoracic injury, that stays tightly closed all the time. So you very gently with a very well lubricated finger need to relax that inner sphincter so that the stool can pass out. Now, a lot of times people don't use enough lubricant, or, you know, it's not something that people have heard a lot about. And so they're like, okay, I'm going to get my finger in there and I'm going to stimulate that sphincter as fast as I can and get out. And when you do it quickly, you're tightening the sphincter and you're making the bowel harder, the stool harder to come out. you're delaying your bowel program. So take a little time doing the digital stimulation. Slow and gentle wins the race here. So the harder, the faster you go, the longer your bowel program is going to be. You take your time and do it a little slower. Really, you can feel that it's about the length of your finger up in the rectum. So that's why we use the one finger. Now, if you're doing a child, look at the length of their finger, and that's how far you want to go in with your little pinky finger, because their rectum's not as big. So getting into this hemorrhoids. Oh, wait, I forgot to say, people with a lower level injury, those in the lumbar and the sacral area have a flaccid bowel, so that inner sphincter does not tighten up, it remains open. They have a lot of problems with, they're out and about, stool rolls out. So you still need to do a bowel program because you want to be socially appropriate. You don't want to be, I always remember this one patient that I had, and she and her husband were out shopping, and all of a sudden, she had a bowel accident, and it was just on the floor in the mall. And so I don't know, they made up some kind of story, and I don't know what they were doing. They turned it into some kind of something and had fun with it, I guess you would say, which sounds kind of weird. I guess I'm not really describing it well, but anyway, they covered it up pretty well. But it's not the kind of thing you want to do when you're out at the mall, or if you're at work, or if you're at school. You don't want to have a bowel accident. So anyway, you have to do the bowel program if you have a lower level injury, just to empty out the lower bowel so you don't have that. Now, all you need to do there is manual removal. So you just use your finger, pull the stool out. Sometimes people do it every other day. Sometimes people do that once a day. There are some people that are so worried about bowel accidents that they'll check their rectum every time they toilet. And that's fine too. Just be sure and use a well-lubricated gloved finger. And so they just do that to avoid their accident. But you'll learn what your own patterns are. So you'll learn when you need to do that. Now about the hemorrhoids. So when you sit on the commode for extended period of time, your legs and your buttocks is supported, but as you know, on a toilet or on a commode, there is that open area. So think about all the weight of your head and trunk and arms. That's a lot of weight that is in your body that's pressing on this unsupported area. So all that pressure is going on your rectum when you're doing your bowel programs. So sitting for prolonged periods on the toilet or on the commode allows all that pressure to go through there. And that's why people tend to have prolapsed rectum, is because all of that pressure of their upper body. So you want to be just on the toilet or commode when you're going to be evacuating. You don't want to be sitting there for prolonged periods, doing dig stim, waiting. Sitting upright is the best position because gravity will help that stool come out. But you want to just do it for the part of the bowel program where the stool is being removed. So you don't want to sit on the commode, put the suppository in, wait 5 minutes for that to work, then do the digital stimulation, then wait a few minutes, maybe 10 minutes, see if that's going to work. Oh, it's not working. So you do more. So people end up to spend hours on the commode. I'm not saying that's what happened in this case, but that is the most frequent kind of thing that happens with the bowel prolapse. Sometimes they do need to do surgery to correct that. Hemorrhoids, if they're left untreated for a long time, might need to be removed. If they're just newly formed, you can take that lubricated finger and gently put them back into the rectum, because hemorrhoids are internal bowel tissue. Internal bowel tissue is not used to being out in the world like our skin is. Our skin is built to take the environment. Internal bowel tissue is much more fragile than our external skin. So with that in mind, if you can catch those hemorrhoids early, then you can gently put them back into the rectum, use something like Preparation H to help shrink them. Always use that gloved, well lubricated finger, because again, if it's not lubricated well, it's, you're going to have that glove up against that very fragile rectal tissue. Now, when the hemorrhoids progress to a certain point and you have that rectal prolapse, obviously you are going to, maybe need to do something about that. What the Paralyzed Veterans guidelines for bowel care, which are great to follow, as well as the information from the REEP Foundation, they recommend removing hemorrhoids not through surgical incision, but doing the tie-off method. So now I don't know about your particular case to the writer who's written in about their hemorrhoids and what they're planning to do for their hemorrhoids. You'll need to follow the doctor's advice. Since they're going to be in doing that rectal prolapse, they might need to treat the hemorrhoids different than just treating the hemorrhoids by themselves. So follow along with what your doctors recommend. You might want to ask about the hemorrhoids being treated without incision because it's hard to heal up, and it can be more challenging than to do the bowel program. It's more difficult, and there's a lot of complications that can go along with the surgical incision. So go ahead and follow your doctor's recommendation. Ask them if tying the hemorrhoids off would be better, but you're still going to have the prolapse bowel taken care of. And then follow the guidelines of using lots of lubricant. I see lots of people come in and they do their bowel program and they have that tube of lubricant and they put one tiny dot on the top of their finger. Now it's goopy and it does tend to, slide off and whatnot, but one little dot on the finger is not going to spread over the consistency of your glove. So generously lubricate that so that you're sure that you have a well lubricated, because you've got to be careful with that tissue in there. And then sit on the commode or toilet only when you're ready to evacuate stool. It takes time to learn about how you're going to do your bowel program, how that's going to work out, how long it needs. So these are just kind of things to think about in that particular scenario. So now we have another question in, and I thank you for these questions because we have a lot going on today. So here's a person who has nerve pain in their arms. Even though they feel warm to the touch, they feel like ice water running through their veins, especially in the forehand and arms. They take gabapentin and tramadol. Those are for nerve pain, but it still gets bad. If I put on a long sleeve shirt, it actually gets worse. Yes, sometimes stimulation to the skin can increase that nerve pain. And so long sleeve shirts are different things. That's not uncommon. So it sounds odd, but yes, you're right. That happens. So anything that might help. This is a C5 quad. So anything that might help. Well, you're on things for the nerve pain. If it's not holding your pain, you might want some, if you're having breakthrough pain, you might want to talk to your healthcare professional about adjusting your pain medication. Sometimes when you're on pain medication for a long period of time, your body becomes used to it and it's not as effective and you have to go up in your dose. And that might be what's happening to you here. So that would be an important thing to find out, is if you need to up your dose or if you need to take a different pain medication. Nerve pain is so unique to every single person. Not every treatment works. It's not like, oh, you have nerve pain, here's the drug for you to take. People take a variety of different medications, sometimes combinations of medications. So you might need yet another medication to add to this. You might need to up your medication. You're on gabapentin, which is specifically designed for nerve pain. It's a GABA drug. It affects the way nerve messages are transmitted, which is the GABA it affects the GABA. It's a chemical in the nerve, one chemical in nerve transmission. Pregabalin is GABA again, is another drug that's specifically made for nerve pain. Some people take gabapentin and it doesn't do anything for them. So they try the pregabalin and it works. Well, who knows why? Some people take other medications such as anti-seizure medications. Some take antidepressants, but in lower doses. They don't have seizures and they don't have depression, but one of the side effects of both of those drugs is it affects nerve pain. And so in real small doses, sometimes people will take those medications. Now, you cannot, this is very important, you cannot just stop this medication and start another medication. You have to titrate off the medication. These medications, your body becomes used to them. And so if you just stop cold turkey, the pain will come on like a roaring train engine. It will be so much worse. You've got to slowly titrate off the medications and then slowly go on the new medication. I know I have so many people who, I tell them this, don't do it, don't do it, don't do it. Especially, I will have to say men, but sometimes a woman, but mostly men. And they'll come back and they say, I just decided to go cold turkey and I was going to tough it out. I am so sorry I did. Yes, because if you go back on the old medication or you start the new medication, once you have stopped cold turkey, it is so difficult to get that pain, which is now roaring, to get that pain under control. It doesn't work as well once it gets that far out of control. You have to titrate off and then you have to titrate on. Now, here's a weird little fact, but this is true. Some people who've been treating their pain for a long time and they, for some reason, want to titrate off the medication and maybe they're going to try something new or they need to make a change or they're, for whatever reason, they need to get off their medication. Something's happening to them and they need to get off the medication. So they titrate off their medication. And when they're off their medication, they discover their pain has disappeared. Now, it doesn't happen for everybody. Nobody knows when it happens. Nobody knows why it happens, but it does happen for some people. So neuropathic pain, once you get it under control and you have it under control for a while, and it can be a long while, sometimes people find they don't need the medication because their nervous system has reorganized itself and it doesn't do that pain pathology anymore. So it's kind of neat in that way. Talk about regeneration. That is certainly one way nerves regenerate, and there's like no feeling to that at all. It's just the way it is. Somebody wrote in that one way to avoid hemorrhoids is to drink a lot of fluids and avoid fried foods and meat. Well, yes, there's fluids certainly help, but not everybody can take unlimited amounts of fluids, especially if you're on a bladder program where you're restricted, or people who have cardiac conditions, or people who have edema where they're on a fluid restriction. So you have to be careful with that, but fluids definitely helps with your bowel program. That's a big thing. And then looking at your diet and looking at things that do not constipate you. So like avoiding processed foods, eating a lot of fruits and vegetables helps. Eating a lot of fiber is very important in the diet as well. So those kinds of things, looking at your diet is very important. So thank you for that tip. And then how can a quadriplegic lose weight with limited access to cardio? Okay, that's a good question because it is very difficult to lose weight. So we had a webinar with Dr. David Gator, if you get a chance to look at it, and he studies this, the late Dr. David Gator, wonderful, just fabulous individual. Since that interview shortly after he passed on, young man, it was a horrible tragedy because he's just so fabulous as a physician and as a human being. He's just fabulous person. But his advice, he studied metabolism and spinal cord injury, and his advice was calories in versus calories out. So talk to a nutritionist, get an order from your healthcare professional to talk to a nutritionist, because the amount of calories that you're taking in because of lack of movement is going to be less than what a person takes in with a lot of activity. Find out what that is. Find out a diet plan for you. I can't say this is the diet plan you should follow because it's going to be different for everyone. So find out what your diet plan should be and then move forward with that. And that will help you gauge your weight. They're working a lot is still in Dr. Gator's program on metabolism and finding different ways to help people lose weight. So that's an important webinar to listen to. Yes, I did say, do not stop gabapentin or pregabalin cold turkey. You need to wean off of those as you do with all the drugs for spasticity. Here's a 55-year-old female, T8 in 2015, motorcycle accident. She has spasms. Oh, yes, I recall this. I think I recall that she wrote this in earlier and I responded to this. Sometimes it takes a while to get my responses. I respond right away as soon as I get them, but sometimes it takes a while. She is having spasms and she's on some medications. So I'm not sure what the question is about that. I know you were looking for some different medications to help you. So again, it's really, it sounds odd, but it's kind of a trial and error to see what works best for different people. So it depends on which nerve transmitter is the one that's kind of acting out in your body. So if it's not the GABA transmitter, maybe a serotonin would work. Sometimes they'll try a combination of drugs. So it's something that you just have to keep working on. There are some people that get on a medication for their neuropathic pain and boom, it's taken care of, and that's wonderful. There are many more people that have to experiment and try with different doses, go up on the doses and try a combination. And so that is often the way that that treatment goes. Also, they're having a UTI and she's been placed on some medications. She doesn't want to take an antibiotic daily. And sometimes, yes, feces get into the bladder. And yes, that happens with women because it's all connected there. You know, the rectum and the urethra, they're not physically connected to each other, but through the genitalia, it's, you know, there's a moist tract that goes from the rectum to the urethra past the vagina, and all of that stays moist in women. In men, the penis is separate from the rectum, so it's not such a problem unless they're wearing like an incontinence device or something like that and the stool gets there. So she's going on this antibiotic again. That's the decision to make between you and your physician, what's the right thing for you, because you want to be sure and take care of that issue. You don't want to have a chronic UTI. Now, there are products on the market that are prescription, and oh my gosh, so many. I know somebody wrote in about the UroShield, and is that something they should be trying? That's something that fits on a catheter that keeps, that has a method of keeping bacteria away from the inside of the catheter or the outside and the outside of the catheter. If you don't have a catheter, oh my gosh, there's some, you know, I see on TV stuff, you know, there's a woman that advertises on TV. I can't think of the name of it. It's her and her partner, Spencer. It's a commercial on TV. And I always think, oh, it's kind of weird. But anyway, she had all these UTIs. And so probably hers is more from sexual, you know, can irritate the urethra and lead to UTI. But anyway, so there are all kinds of treatments for UTI. And again, you just have to find the best one. And to say, oh, it's not a matter of hygiene, because emissions leak out of the rectum through gas, fecal materials. Sometimes there's some oozing, and you can have vaginal secretions, and it all mixes in, especially with the female, it all mixes in the urethra, and so it makes you more susceptible to UTIs. Really, what comes down with UTIs is it's a matter of your autonomic nervous system, the ANS. So that's the part of your body that controls things automatically, like your heart beating and your breathing. And okay, so we all know that, but it also controls the immune system. So some people don't really do much to the care to the urinary tract at all, as far as hygiene or catheter care or whatever it is they're doing. They never have a problem because their immune system has not been that affected by the spinal cord or brain injury. Some people are pristine about their hygiene, washing their hands carefully, doing everything by the book, by the letter, never missing a time schedule. I mean, just everything they're doing. And they have all kinds of infection. It's probably because your autonomic nervous system has been more highly affected. Whose nervous system is more highly affected and who's not is very difficult to tell. Testing the autonomic nervous system is a highly risky procedure, and so it's just not done to to find that. But we do know people who have more infection probably have more issues with their autonomic nervous system. So that's probably it's not an issue where you're doing something wrong. It's an issue that it's probably just your autonomic nervous system. So if you're advised to take an antibiotic just to keep that at bay, that might be your best bet until we get more information. There are people that are working on the autonomic nervous system and trying to help that takes care of spasticity, takes care of infections, takes care of autonomic dysreflexia, this whole plethora of things that are controlled by the ANS. So they're working on this in a bigger picture kind of thing, and that will be great when they get that figured out. That's yet to come. So again, possibilities. It probably won't come this year, but again, a possibility. And is hair loss common? Yes. Hair loss can be common after any kind of traumatic accident. And there's also something happens, again, the autonomic nervous system, your hair grows automatically. We don't think hair follicles grow, but it does happen that hair will fall out over time. Now, men will take testosterone and sometimes reinvigorate their hair. For women, it's a little more complicated, and there are different products that will help thicken your hair, volume products, and those kinds of things. So that might be the kind of thing that might be needed. Oh, here's somebody who's having uncomfortable cramps that twist her fingers with pain. She has an L5, so that does not affect her hands, but she fell in her wheelchair and she hurt her hand. And so that's probably the spasms and the nerve pain. That's probably from some kind of nerve that's been affected in your hand. So you might want to check with your healthcare professional to see what's going on in your hand, because you don't have to put up with that. So you've heard of carpal tunnel syndrome. And if you have nerve pain that's in these two fingers and the side equal to it in the middle finger, it's usually an impingement of the nerve, the median nerve right here in the wrist, and that's a carpal tunnel injury. If you have nerve pain that's in these two fingers, the pinky and the ring finger, and on the side of the middle finger that is next to them, that is a cubital tunnel injury, impingement of the ulnar nerve in the elbow. It could be both, or it could be up in your neck if you got, if you got jarred, if you pushed your hand out and it got jarred up here in your neck. So be sure and have your talk to your doctors about your nerves in your hand, because those are peripheral nerves and you can do releases on those nerves, and the nerve will get more blood flow to it and it can help resolve that issue. Now, sometimes if you wait too long, it can be more difficult, more challenging to have that return of function. So do talk to your healthcare professional about that, because that is going to be a fix. It's not an easy fix, it's surgery, and surgery for everyone is risky. Surgery for people at any level has more risk with a spinal cord injury than people who do not. So, consider all your options, and, you might need to even just wear a splint or something for a while that might help resolve that. So these are all kinds of things to think about, because there's something going on in your hand. It's not related to your spinal cord injury. So you might need a hand specialist to help you. Maybe just some therapy might help resolve that as well. I say just therapy. Therapy is a lot of effort and work as well, but it's not surgery, but that might be, or even maybe an injection of some kind to help you with that. There's somebody else who wrote in about their having hand pain pushing their wheelchair. Also not an uncommon thing. Some people will wear gloves. That's an easy fix. Sometimes you can get rims that are different that might help with your hand pain. Sometimes you can get something called a push assist on your wheelchair, which is a little motorized gizmo that you just barely have to touch your rims and zoom, it just takes you. It helps you manipulate your chair. It is a very heavy device. So if you're getting your chair in and out of your car, it's heavy to lift and you have to attach it. It can be in the wheel. Sometimes it's a motor that's attached. The newer ones are actually in the wheel system. And so that can make your wheelchair a little bit harder to move, but it really is a big help. Again, there's a question about all these different treatments for UTIs. Different people do different things. Some people will swear by one thing and other people will say, oh no, that didn't work at all for me. The ones that they were asking about in this question was D-mannose, and that has a lot of sugar in it. So diabetes is a complication of spinal cord injury, a secondary complication. You want to keep track of your sugar intake. Cranberry juice, it also has even the non-sugar added cranberry juice that has the non-sugar product sweeteners in it instead of the sugar. Those can act in your body. Your body can react to those the same way it acts to sugar. So you want to be careful of those. But this is another question that they had, is that they have a productive cough. And they were asking about guaifenesin, which is an expectorant. It's a cough medicine you take and it breaks up the mucus in the back of your throat and in your lungs. Years ago, and I'm talking years ago, back when I was a baby nurse, we gave guaifenesin to everybody who had thoracic or cervical injury. Everybody got it. Well, everybody didn't need it, but back then, you know, it was the thing. And it broke that up and it's helpful. You cannot take that if you have high blood pressure. So that's something to think about. Now, if it's much worse, there's this vest that you can put on and it kind of does this percussion in your lungs, which helps break that up. So that's non-medication. So that's kind of a nice thing to do. It's more expensive treatment. It's more time consuming than just, well, I'll take my guaifenesin now, but it's very effective. And then albuterol or nebulizers, those help with lung constrictions, as well as with getting some of that gunk out of your lungs. So, you know, whatever your physician recommends that's best for you is the thing that you should be doing for that. Somebody was asking if there's any webinars other than Wednesdays. Mine are on Wednesdays. I think Dr. John is on Tuesday, and I'll have to ask Beth to correct me on that, but I think I listened to him on Tuesday. But they're all available on the YouTube channel. So if you miss one, you don't have to worry. You can listen at any time that's convenient for you. Another question is about muscle wasting in the legs if you're paraplegic. Those people who have lumbar or sacral injuries have what's called an atonal or without areflexic injuries. And so their muscles are not even getting the stimulation of the spasms. And so the muscles tend to shrink down to real small size. However, with therapy and some of these different therapies that you have, there is a potential to build back those muscles. There's also, because in the lumbar area especially, there's nerve transfers and nerve grafting procedures that can help create some movement, provide that feedback to those nerves in your legs and help bulk up your legs. So there are things that are available to you. The electrical stimulation doesn't stimulate this nerves because they're atonal, but there are other options for you. So that is very helpful as well. I do want to mention, we're coming up to the hour, we're past the hour. I do want to mention that there's some other things that are coming up shortly on February 22nd, which is the Ask Linda webinar at the end of February. So February 22nd at 2 p.m. we're having Justin Graves, who's a member of the community, who's going to talk about his advocacy and also about travel. And, you know, it'll be very interesting just to hear, he's a big time traveler. He goes all over, you know, just to hear what his impressions are, how to, you know, some of the tips and tricks to traveling. I think there's some fear sometimes of people about, you know, all the stories that they hear. So how to get prepared and do all of that. So that'll be really neat. And then also coming up in March, we're going to have Dr. Christina Sadowski from the Kennedy Krieger Institute to talk about activity-based recovery, both for adults and pediatrics. So you'll want to tune into that. So a lot is coming up. And if you have any questions, please put them in. I answer every single one of them the day that I get them, usually, sometimes the next day if it's late at night, but every single day. So please feel free to write in. If you don't get a response, you know, write back in. I didn't get a response because something's happened that I didn't get it, because otherwise I will respond to you. But thank you for tuning in today. It's always nice spending time with you, and I'll see you next month.